Hello, everyone. Welcome back to the Physio Almanac. This is the part two of the cardiorespiratory assessment, the objective assessment. We have already completed the part one. You can look on the channel and you would be able to find the part one of the cardiorespiratory assessment. But before we begin the session for today, just a request. If you like the video, please make sure to share it, like it, and subscribe to the channel if you have not done yet. And also, if you know anyone who is preparing for their clinical exams or needs help, even a physiotherapy student who just needs a bit more of information, and if you think that we have been able to help you, please make sure to spread the message across so we can reach to as many people as possible. All right, let's begin. So, the objective assessment is the second part. So, remember, we've already seen the patient, we have got their history, we know why they're admitted in the hospital or why they have come to see you in the OPD or the clinic. So we have set their goals, we have discussed about their cough, their sputum, their shortness of breath, their chest pain, their functional mobility. We have already discussed about all those things. And now we are going to begin with the objective assessment. So in the objective assessment, specifically, it is divided into three components. We have the look, that is the observation part. We have the listen, that is the auscultation part, and the feel, that's the palpation part. So, what exactly we will be doing? One of the most important things that you have to remember, especially in a cardiorespiratory patient, is the vitals assessment. Now, whether you should do the vitals assessment just at the start of the objective assessment or as soon as you enter the patient's room, that will depend on how acute the patient's condition is. So imagine first day post CABG or second day post lobectomy, which was a complicated surgery, let's say. That time you would take the vitals as soon as you enter the room. Or let's say the patient has had an uncomplicated surgery but has developed complications after the surgery. They have developed fever overnight. The nurses, when they are giving you the handover, when you are going to enter the patient's room, they tell you that the patient was not well, was presenting with green colored sputum, had a fever overnight, increased respiratory rate, and is on antibiotics. So in that case, you would probably need to do the vitals assessment as soon as you enter the patient's room. If not, then you can do that at the start of the objective assessment. So these are the normal values of the heart rate, respiratory rate, blood pressure, saturation, and temperature. So for the temperature, you can use the ear probe for measuring the temperature. An increased temperature is usually indicative of an infection in the body. Saturation is 95 to 100%. That is normal, but this is for a normal person. Let's say a person who has had a rib fracture does not have any comorbidities. Patient who has COPD, and in chronic COPD cases or chronic respiratory disease patients, you may have differences in your saturation. So if you remember, it's between 88 to 92%, but it can vary for a patient. So if a patient has a particular respiratory condition, make sure to ask for their baseline as to what is your normal saturation level. Blood pressure 120 by 80 mmHg. So 120 is your systolic, 80 is your diastolic. Respiratory rate, and yes, sorry, the blood pressure you can measure with a cuff on the left arm. You can measure it on the left arm, right arm, but make sure to be consistent wherever you are putting the cuff. For respiratory rate, it is 12 to 18 breaths per minute. Increased respiratory rate can be an indicative of infection, stress, fever, many other things. So make sure that you check the patient's respiratory rate in such a way that they are not aware that you are checking their respiratory rate. So you put your two fingers on the thumb side of the wrist and then you measure it for 60 seconds. Make the patient um, not know that you are measuring the respiratory rate. So we are looking for the rise and fall of the tummy, and just verbalize that you are going to be checking the patient's heart rate. Just tell them that you're going to count it. Now, the heart rate can be displayed on the pulse oximeter, or if there are any other devices that are attached to the patient's chest, that would give a display of the heart rate. That is 60 to 100 beats per minute. Moving on. Now, before we are going to touch the patient, before we are going to start the objective assessment, make sure to ask the patient for consent, making sure, like, you can say something of this sort. So, all right, Mr. X, I've taken whatever information I needed from you, and thank you for providing me with so much of details. Now, I would like to begin with the second part of the assessment, that is the physical examination. Here, I would be having a look at how your chest wall and your lungs are moving. I would be having listen to your chest and your lungs, and also I would be feeling for your lung movement. Is that all right? The patient says yes. Okay. Now, the first part of the objective assessment, now I'm talking about after you've done your vitals, is your observation. So even when you enter the patient's room, at that time also you can observe the patient. So whether the patient is calm, he's distressed, he's sweating, and that would give you an indication of whether the patient is having difficulty to breathe, or is sweating. So is he struggling? So just an indication of how he is appearing to you. Also note the color of the face and the lips. So we are looking for whether there is any bluish discoloration, which indicates cyanosis or reduced oxygen in the blood. We look for nasal flaring and pursed lip breathing. This is also an indicator wherein the patient does not have enough of oxygen in the body, in the blood, and he is kind of stressing um, and compensating to by expanding. And it's not really a voluntary thing, it may be involuntary, unintentional, and the nostrils are flaring, or the patient may be breathing through his pursed lips. I've seen many patients who have chronic COPD. That's their pattern of breathing, because how that's how they feel better, or how it makes them easier to breathe. Also note their breathing pattern, whether there's any accessory muscle use, whether they are using their lower rib cage, whether they are raising their shoulders up when they are breathing. Also look at their posture, so whether they are leaning forwards. Again, patients who have respiratory disorders and breathing difficulties, you could see them in a leaning forward position. I've seen some of the patients who are obese maybe leaning backwards in the chair, but it's just for the ease of the movement of the diaphragm, whatever works. But it's usually an indicative that the patient is having difficulty to breathe. You could also check their cuff strength if you want to do it now, or you could do it later. So, or if you have done in the subjective assessment, you do not need to do it now. So you would just say, okay, can you show me your strongest cough? So then you would see whether the patient is using their tummy muscles, how strong their cough is, and whether they are able to produce any sputum. All right. So the first picture that you see in the patient in the hospital, that's a tripod position, commonly used by patients who have respiratory disorders and breathing difficulties. So their forearms would be supported on the thighs and the knees, and it allows for the diaphragm to move in an easier position, which exactly is a similar picture on the opposite side, wherein you can see the patient is trying to brace his upper chest by putting the hands on the knees and the thighs. So it helps the patient to breathe better and comfortably. You could also see the accessory muscle use. So we know these scalenes and the sternocleidomastoids are trying to lift the upper part of the chest, upper rib cage, the first, second ribs, and the top of the sternum, to move it up if the patient is having any breathing difficulty. So that means the diaphragm's not working as effectively as it should be. Now, the second thing is you would be looking for auscultation, and we are auscultating for a whole inspiration and a whole expiration, right? And what are we trying to hear? We are trying to assess the breath sounds. So we are trying to assess whether the breath sounds are normal or they are abnormal. All right. So the instructions that you would give to the patient is, I am now going to listen to your breath sounds. Please do not talk to me when I am listening to your chest. If you have any problems, please raise your hand. The stethoscope may feel a little cold. Is it all right? Can we proceed? Then then you can say, when you feel the stethoscope on your chest, can you please breathe in and out of your mouth a little deeper than normal? So these are the instructions that you should be giving to the patient whom you are going to auscultate. Now this is a very important part wherein you are going to put the stethoscope of the patient's chest, and especially if you are a male physio who is going to auscultate a female physio, so make sure that you are covering the areas that you do not need to auscultate. The patient should be feeling very comfortable when you are trying to auscultate their lungs. All right. And giving instructions is going to be good, so that the patient is not talking to you when you are trying to hear what's happening. Now, these are the auscultation points. So, the right side of the picture is the front of the chest, and the other picture is the back. So, remember, the auscultation points are looking at the upper lobe, middle lobe, and the lower lobe. Only the right lung has the three lobes, the left lung has two. And what you are trying to do is you are auscultating at the second, fourth, sixth, and eighth intercostal spaces. So at the second intercostal space, you are looking at the upper lobe. The fourth one, you are looking at the middle lobe. And the sixth and the eighth is for your lower lobes. So make sure to move from right to left. So you auscultate first on the right, then go to the left, then come to the right, then come to the left. So what we are trying to do is we are comparing the right side of the chest to the left side. So comparing the left upper lobe with the right upper lobe, left middle lobe to the right middle lobe, left lower lobes with the right lower lobes. The same way on the opposite, on the back, is T2, T4, T6, and T8. We are auscultating the upper lobe for a small area and mostly of the lower lobes. This is the picture of the stethoscope. So you are keeping the diaphragm on the patient's chest for auscultating. All right, I hope this is clear. Now, coming to the breath sound. So, we have the tracheal, the bronchial, the bronchiovesicular, and the vesicular breath sounds. So, these are your normal breath sounds. So, the areas are marked. So, the tracheal breath sounds is where you would hear them directly over the trachea. The bronchial would be just over the manubrium, so just above the clavicles. Bronchovesicular would be on the first and the second intercostal spaces, and the vesicular breath sounds, which are very soft and low pitched, would be all throughout the lungs. The abnormal breath sounds usually can be a wheeze, a ronchi, or crackle. So, or a stridor. Stridor is usually for the upper airway obstruction, and as you are going down into your airways, you can hear a wheeze, which is usually indicative of bronchospasm, commonly seen in patients who have asthma or airway narrowing. Rhonchus is a similar way that you would be hearing, but it's more low pitched. For crackles is like paper crushing sound, that you are trying to crush the paper, and it's indicative of retained secretions. um, and plural rub is indicative of your inflammation. So as I would suggest look up some YouTube videos to hear exactly how the sounds sound like, and that would be of help. All right, so quickly again, the normal breath sounds and the abnormal breath sounds. Moving on, the last component is your palpate. So, what are we doing? We are looking for the chest expansion, we are looking for the breathing pattern, basically. So, again, the instructions, I am now going to have a feel of how well your lungs are expanding. I will be placing my hands around your lower rib cage and feel for the chest wall movement. Is that all right? Can we proceed? Can you please take breathe can you please breathe in through your nose and out of your mouth a little deeper than normal? Now, also, one thing that I want to tell you, when you are auscultating and when you are uh, palpating, make sure to give the patients appropriate amount of rest, because we do not want them to get really tired, especially if the patient has been in the hospital and there are many people who have been trying to auscultate or palpate their chest. Also, giving proper instructions is very important, and we are not pushing our hands into the patient's chest. We are just keeping them gently to feel the rise, to feel the movement of the chest wall. So, feeling whether the ribs and the lungs are expanding and whether they are relaxing on expiration. All right. So now, coming back to this slide, we talk about DVT. So now imagine you have gone to the patient's room, you have been talking to the patient. The patient, scenario one, the patient has had a coronary artery bypass grafting 3 days ago and has not been able to come out of the bed. So you would probably need to do a deep vein thrombosis assessment, even though that you are assuming that you would have been notified if there was a complication. But as our duty of care, it is a good idea to check for whether the patient is having any pain at the back of your leg. So you can just stroke your hands at the patient's back of patient's legs, or just look for redness, just look for swelling, any temperature changes, any warmth. So just see before you mobilize the patient. Also, another thing is mandatory: if the patient has not got out of the bed or has had a surgery, make sure to check the patient's lower limb muscle strength before you make the patient out of the bed, get the patient out of the bed. So imagine you enter the patient's room, the patient is lying down, you may raise the head end of the bed because you want them to be able to talk to you easily, to be able to have good lung expansion, and it's it's better for them because they would be a little bit upright. You've taken the subjective assessment, then you start with the objective. Now you can start the objective assessment from patient in a half lying position, but you can also make them sit at the side of the bed. Now, again, depending on the acuteness of the patient, you could also make them sit in a chair next to the bed, depending on the acuteness of the patient. And also make sure, as I said, to check the muscle strength before you actually mobilize the patient. Find out whether the patient has walked since the surgery, has walked since admission, whether the patient has been using a walking aid, not been using. Make sure to use your clinical reasoning and judgment whether the patient needs any assistance with any lines, any drains, any tubes before you actually get the patient out of the bed. So make those decisions before you get the patient out. Again, checking for DVT is a similar thing. Whether you need to check or not check, it will just depend on what is the case. Has the patient not mobilized? Has had a surgery 3 days ago? Probably I will. If the patient has been mobilizing, walking around, has had no problems, I will not. Right? But make sure, do not take the bed sheet off if the patient is lying down in the bed, right? Especially, again, as I said, if it's a male physio treating a female patient, respect the patient. Their dignity is very, very important, as for any of us. So make sure to take consent. Is it all right if I take a quick look at your legs? Are you able to move your ankles up and down? Do you have any pain at the back of your legs? I'll just feel for warmth at the back of your legs on the calf. Is that okay? So just taking consent. All right. Now we have observed the patient, we have auscultated, we have palpated. Now what? Now we have a problem list because we have already done our subjective, we have done our objective, and we now know what is the patient's problem. Why does he need physio or cardiorespiratory physio, or why does he need a respiratory physio, or in other words, why does he need to see you? Okay, so if the patient is having difficulty clearing sputum leading to retention of secretions, so in cardio, what you have to understand is, you first thing first, you should know the pathophysiology. You should know what is the patient's problem. Is the patient not able to clear sputum? Let's say the patient is day one abdominal surgery and has COPD as a comorbidity, past medical history, is 65-year-old obese who is a smoker, may be having difficulty clearing sputum, which is leading to retention of secretions. Or the patient is having an increased sputum production because the patient has bronchiectasis, or the patient has cystic fibrosis, or the patient is recovering from an or the patient is having, not recovering, a patient is having an exacerbation of his COPD. So that's leading to increased sputum production. So understand what is the problem, and there is a difference between the problems. Both of them can lead to, or one of them can lead to retention of secretions. But retention of secretion is when the sputum is there and the patient is not able to clear it out. Whether the patient is unconscious, whether the patient is cognitively impaired, not able to follow your instructions, whether the patient is a young child, whether the patient is having thick secretions. So, what exactly is leading to the secretions being retained in the lungs? Okay, now the patient may be having shortness of breath at rest and or exertion. Why is the patient having shortness of breath? Because, could be, I'm saying, the airways are narrowed. Why are they narrowed? Because of bronchoconstriction. Does the patient have asthma? Does the patient have increased mucus production leading to narrowing of the airways, which is causing him to have shortness of breath? Is the patient deconditioned? Is the patient not having enough um, muscle strength, or is the body not able to utilize the oxygen properly, or is the patient having poor functional endurance? So what exactly is causing the shortness of breath? The patient may be having an increased work of breathing. As I said, the patient is having narrowed airways due to the secretions which have caused the patient's lung and muscles to work harder. And obviously, if the diaphragm is not working properly, the accessory muscles would have to be recruited. Is the patient having a decreased lung volume or poor ventilation and gaseous exchange? Why would that happen? Does the patient have a restrictive lung disorder that restricts the expansion of the lungs? Does the patient have a, I don't know, maybe a recent lobectomy? So he's having an incision on his chest wall that's causing him to have pain on chest expansion, and that's why he's trying to breathe at a low level, or having a shallow breathing pattern because he's having pain and he's trying to protect his chest, or mastectomy, let's say. Reduced exercise capacity. The patient has been having a few hospital admissions and is completely deconditioned. He is not having enough of strength overall, is fatigued because of the medications, is tired, and is not able to perform at his usual self? Is the patient having a decline in overall muscle strength and deconditioned, as I said before? They may also be having difficulty to perform their activities of daily living and recreational activities. So, as a result of the cardiorespiratory problems or the respiratory issues, the patient may be having functional limitations. So, what we are trying to do is we are trying to actually find out what exactly are the functional limitations and what is the source of these functional limitations. All right. The last thing that we do is, after we know what the patient's problem is, we decide on the treatment. Now, pursed lip breathing training can be given for patients who have shortness of breath, right? So we tell them, I want you to try and think as if you are smelling roses and blowing out candles. Or I want you to breathe in for the count of 2 and breathe out for a count of 4. If you try it in a forward leaning position, it would be helpful for you because the main muscle, which is the diaphragm, would be able to work better. ACBT, so that's active cycle of breathing technique. If you need any help on that, please let me know, and I'm happy to make a detailed video on that. But it consists of 3 components, which you can modify depending on what exactly the patient needs. So, does the patient need more breathing control because he's short of breath? Does the patient need more thoracic expansion because there are more sputum, retained sputum, and you need to get the air behind the sputum? Or the patient needs more of forced expiratory technique, that's huffing, to get those airways from the peripheral airways to the central airways, that they can be cleared out by huffing. So it's, but importantly, we call it ACBT when you have all these 3 components: breathing control, thoracic expansion exercises, and your forced expiratory technique. You can modify it as per the patient's requirement. Coughing or huffing, depending on, we have already done the assessment of the patient's cough strength. So let's say the patient is having pain on has had an abdominal surgery, and he's not able to recruit his abdominal muscles sufficiently to produce an effective cough. So we give them a towel and then try to splint it and then try a strong cough. Huffing would be less painful, less intense, and more easier. But usually, huffing is utilized to get these secretions from the periphery to the central airways. From the central airways, you can take them out by coughing. You can also, as a treatment part, you can educate the patient on the use of puffers, spacers, discuss the patients about their action plan, so asthma action plan or COPD action plan, so that do not have to have a hospital admission, um, and their symptoms can be managed before there is a requirement of coming to the hospital. Or maybe they do not come to a condition wherein the symptoms become bad. So well before they know that weather is going to change, or they know that they have to take their medications in time so that their symptoms do not get bad. Discussion about a pulmonary rehabilitation program or regular exercising or smoking cessation. Remember, when we are doing education about smoking cessation, we are not judging the patient in any way. We are just asking a simple question: whether the patient smokes, does not smoke, has he thought of quitting, and if he needs any help for helping him to quit. So that's all we need to know. About pulmonary rehabilitation and exercise, it will depend on whether the patient is having a sedentary lifestyle, what is the patient's routine, and what are the patient's interests. A patient who tells you that I like to get up in the morning and do Tai Chi, and you tell them, no, I want you to run every day, would probably not be interested. So again, modifying exercises as per the patient's choices is important, so their adherence is more. The last one is your walking program or mobilization out of the bed. All the surgical patients or any patient who has been admitted to the hospital, make sure walking is a very, very good exercise. Why? Is because it helps the lungs to expand. It makes the patient feel better in themselves as well, and the body utilizes more oxygen, so that means they are getting stronger in an indirect way, because their body is utilizing the oxygen properly. If not at the first session, gradually the body will become accustomed to it, but also the lungs get more air in, and when they are walking around, then the lungs are kind of forced to take more air in, and also helps them from a psychological point of view. So, walking is a very good exercise, and especially mobilizing out of the bed. You could educate the patient that for every time that you are spending staying in the bed, it's uh, um, harming you, or having a harmful effect on your body. So there are different ways to educate the patient. Please make sure, like, please let me know if you need any information, or if you need me to discuss any of these treatments in detail, and I can take those sessions as well and help you with all the information. But mobilization out of the bed is very, very important for increasing the lung volumes, increasing the lung capacity, psychological benefits, and utilizing the body's oxygen. So these are the treatments which you would have to tailor according to the patient's presentation. Moving on, these are the references from where these slides were made. And that's it. That finishes the session on the objective assessment of a cardiorespiratory patient. Please let me know what exactly you need help with, and I will try and help you. But just a quick recap: remember to take the vitals assessment. It will depend on the acuteness of the patient. We will try and include these components which are a must, and your observation of the patient. You auscultate, make sure to give them proper instructions, and palpating the chest, feeling for how well the lungs are expanding. Then you come up with the problems. Also, make sure to discuss the problems with the patient to be able to explain why are you doing a particular treatment. So just tell them 1 2 3 4, these are your main problems that I can understand from your assessment today, based on what we have discussed and based on what I have been able to find out from having a listen to your chest and feeling the movement of your lungs. And I would like to work on these things with you by, number one, by pursed lip breathing, or teaching you strategies how to cough effectively, or coming out of the bed and mobilizing, and educate them. So once the patient understand the reason of why you are doing, of what you are doing, the adherence to the physiotherapy treatment is much more. And once they adhere to the treatment, um, your job is done. So yeah, explanation, I think, is very, very important, and educate your patient. That's all from me today. Thank you so much for joining in, and I will see you all in the next one. Thank you. Hope this was helpful.